Hi, my name is Dr. Kathleen Gibson, and I'm going to talk to you about Venaseal closure of the saphenous veins and lessons that I've learned after 6 years of use. These are my disclosures. Examples of disruptive technology in medicine include things like open cholecystectomy, which now has largely been supplanted by laparoscopic cholecystectomy, and open prostatectomy, which has now been often replaced by robotic prostatectomy. So what does a new technology need in order to succeed? It needs to have efficacy that is equivalent or better than the standard of care, approval by a regulatory agency, and if it's not better, it needs to have specific advantages to the patient, such as improved quality of life, faster return to work, improvement in appearance, etc. If it's not cheaper, then the advantages must be worth it either to the physician or to the patient. And in order to succeed, you have to have the right physician performing the procedure using the right technology on the right patient. Historical options for the treatment of chronic venous insufficiency have ranged from surgical treatment to medical compression stockings to the endothermal ablation techniques, radiofrequency, and then laser, followed by sclerotherapy, and now adhesives. How can we improve on endothermal ablation? Well, first, we can eliminate the need for tumescent anesthesia. Second, reduce the bruising that is often occurring when tumescent anesthesia is being performed. Allow the patients to return to normal activities faster, eliminate the need of stockings, and reduce the risk of nerve injury or burns. The right physician for this kind of new technology is one that understands superficial venous disease, is trained in ultrasound and understands the anatomy, is experienced in venous access and venous closure, and has good judgment to pick the right patient. Proper patient selection includes picking patients that have truncal saphenous incompetence that's long enough to use Venaseal. So you need to be back from the saphofemoral or the saphopopliteal junction at least 5 centimeters. And if the length of vein that you want to treat is much shorter than that, or barely longer than that, it doesn't really make sense. So for example, if you had a patient with a 7 centimeter segment that you wanted to treat and you needed to be back 5, you would only be putting Venaseal in 2 centimeters. So this may not be the best technology for that. The patient should have no history of adhesive or cyanoacrylate allergies. They need to be accepting of new technologies and understanding that this is a permanent implant. My first lesson to discuss is how short-term differences differ from endothermal ablation. So my usual aftercare for endothermal ablation is that the patient would ambulate immediately. I don't stop anticoagulation if they're taking it, but I put them in compression stockings for up to 2 weeks. They usually go back to work the next day and usually take a couple days before they'll go back to working out. Typically, they'll need to take non-steroidal anti-inflammatories and usually will not drive to and from the appointment, but would go back to driving the next day especially if they haven't been sedated. For my usual aftercare for Venaseal, they immediately walk. I don't stop anticoagulation. They usually do not require compression stockings. They'll go back to work the same day. I don't put any restrictions on working out. Many of them go back to exercise immediately. Same pain care regimen, non-steroidal anti-inflammatories, and drive usually home from the clinic appointment. So we found in the WAVES trial, which was a study that we conducted at our site, looking at patients with cyanoacrylate closure, that the time back to work, most patients went back to work the same day of the procedure. Some patients went back to work the day following, but most of the time they did not take time off work. And time back to normal activities, meaning full working out, was average of 2 days. And 29 out of 50 patients went back to exercising the same day as the procedure. This patient that took 20 days to go back to working out was a yoga instructor that wanted to wait a while. So my usual procedure follow-up with patients with Venaseal is that I usually will stage the tributaries or branches, except for cases where the branches are really large, if there's a wound, or if we have what we call bucket handle varicosities, where you have a branch going in and out of a saphenous vein, and I'm concerned that it will thrombose and be painful. Then I may do phlebectomy at the same time or sclerotherapy. I see them back at 1 to 2 weeks to assess for complications. I look at their tributaries. If they need a duplex ultrasound for some reason, we'll do it then. Many times none is needed. And at 3 months, I again assess for complications and I look at their tributaries and see whether they need to be treated. So my second lesson is that staging the branches rather than treating all at once works well in most cases. And this is a change from what we used to do. When we used to do vein stripping, we would remove all the branches at the same time. And when we started doing endothermal ablation, we usually would follow that pattern because that's what we were used to. We found out, however, oftentimes if we would stage branches that this was unnecessary as they would often regress. And I'll show you some examples in a moment. So we looked at this specifically in our WAVES trial, which was again a study of 50 patients. And there were a number of physicians participating, and we asked them ahead of time, if we were to let you do whatever you wanted during this procedure, either phlebectomy or sclerotherapy, how many phlebectomy incisions or sites do you think that you would need to make, or how many injections do you estimate you would need? And then we looked at 3 months and saw what procedures needed to be done with staging. So everyone was staged for the trial. And at 3 months, we saw what procedures needed to be done to clean up branches. And the patients did have discretion to turn down more phlebectomy if they wished. And we did a scoring where we said that the procedure score was phlebectomies times 2 plus number of injection sites. And so the physicians had predicted that 74% of the time the patients were going to need phlebectomy if they did not treat them at the same time. And we found that only 14% of patients did. They estimated that 90% of the patients would benefit from sclerotherapy, and 2/3 did have sclerotherapy. So the number of procedures that the doctors predicted the patient would need was shown here in these green bars. This is phlebectomy plus sclerotherapy, and the red bar is what actually happened. So there were only 2 cases out of 50 patients where the number of phlebectomies needed or sclerotherapy amount needed was more than what was predicted. Everything else was less. So a few case examples. This is a gentleman that was in my practice that he had some pain, a little bit of ankle swelling. His anatomy was his anterior saphenous was incompetent, as was his great saphenous. So both veins were treated with Venaseal. So this is before. We staged his branches. This is pre-procedure. And then this is his 1-month visit, and the branches are still there, but they're getting smaller. And then at 3 months, this is how he ended up looking. And while you can see a few residual branches, he elected not to have any treatment because he was pretty pleased with how things looked. Here's another example. This is a woman, a school teacher, having pain from varicose veins. Her great saphenous vein is incompetent. And this is pre-procedure. And then this is at 1 month. And then at 3 months. And then here she elected for me to do some sclerotherapy. If I had done concomitant procedures, I probably would have made maybe up to 10 small incisions if we had not staged her. So my third lesson is that long-term outcomes are favorable. So we have 5-year data, both from the V-Close extension trial and from a study that we did in our office looking at patients that were not part of the original clinical trial. So the V-Close data, the V-Close trial was a randomized trial comparing Venaseal to radiofrequency ablation. This was the pivotal trial that led to FDA approval of Venaseal. And it was then after the first 3 years, we did not collect data the 4th year, but on the 5th year, we collected data and we found that closure rate, complete closure by Kaplan-Meier, was no difference at 5 years comparing Venaseal, which is the top here, and radiofrequency ablation. So 85% compared to 91%, and this was not statistically significant. The second number here is including some roll-in patients. So these were patients that were not randomized in the trial, but were used to have the doctors familiarize themselves with how to do Venaseal. And the closure rate was excellent. At 5 years was 94.6%. So the V-Close 5-year extension study results also looked, besides closure rates, at secondary endpoints of VCSS. Venous clinical severity scores were equal compared to the two groups. The Aberdeen Varicose Vein Questionnaire, which is a quality of life survey, was no different between the two groups statistically. The EQ5D, which is the visual analog scale about improvement in health status, was also no different. And it was found that the adjunctive treatments needed for patients in between the 3-year study and the 5-year study were similar and not very high in either group. So 4.3% in the cyanoacrylate group compared to about 9.3% in the radiofrequency group. So also the SEEP class improved in both groups. Again, this is not a scale, but a classification. So this is original, more C2s than others out to C4B. We didn't allow ulcers in this study. And there were improvements in both groups. There were no serious adverse events found long-term with Venaseal. There were no new adverse events between 3 and 5 years. And overall, the patients were very satisfied with their treatment. So the new WAVE study, this is one that we did in our practice. It was our second WAVE study, and we looked at all patients that we treated either as part of the WAVES trial or just in regular practice because Venaseal had then been approved, that had reached 3 years of follow-up. And we took a look at a number of things, including closure rates and quality of life. So the total number of patients that we enrolled were, in terms of eligible limbs, we had 135 eligible limbs, and we enrolled 114, so 89 out of 110 patients we captured. These were the patient characteristics. So the mean GSV diameter was 7, ranged from 4 to 14 in terms of an average diameter. The largest segment that we treated was larger than that, but this is the mean. And you can see the distribution of patients here that we included. We didn't have any open ulcers in this group, but we included some more advanced disease classifications. And looking at outcomes, we found that complete closure in the GSV was present 97% of the patients, anterior saphenous 80%, and overall closure rate was 94%. 3 GSVs had openings that were less than 5 centimeters in length in terms of the open area. And this shows at baseline blue, the SEEP clinical class, and at 3 years. So there was significant improvement. And we also saw improvement in VCSS, quality of life, and visual analog scale. So this was not compared to radiofrequency, but as good or better than what was found in the VCLOS trial. We also asked the patient about whether or not they felt their leg looked better, and the majority of patients felt that their leg looked much better, that their symptoms were much better for the most part, and almost all of them were quite either completely or somewhat satisfied with the procedure. So we were pretty pleased with those results in our own practice. So my fourth lesson with Venaseal is that Venaseal is a good option in elderly patients. And what I thought was an ideal Venaseal patient when I first started using it in 2016 was a young and healthy patient that was active, doesn't want to wear compression stockings, and wants to work out right away. So what I found over time is that the patients in this scenario do very well, but the group where this really shines is the elderly. And the reason why is they have limited mobility, and anything you do to them that makes them sore will make this mobility worse. They have great difficulty putting on stockings. Even if they have a spouse or someone to help them, that's difficult. They need to maintain their mobility, and a lot of them have comorbidities such as thin skin, they're on blood thinners, and the less you do to them in terms of disrupting their routine, the better. And many of them have very advanced venous disease compared to the younger patients. So some considerations in geriatrics is that mobility may be an issue, that they may find that positioning of their limb is difficult. They have trouble turning their hip out, like what we have to do for radiofrequency or laser ablation. They may have risk factors for complications of tumescent anesthesia, such as blood thinners or thin skin. Some of them may have a tenuous volume status, and even though we feel like we don't give a lot of volume with tumescent, it can be an issue if the patient has a history of heart failure. They may not tolerate sedation very well. A lot of them have difficulty with compression as well. So in terms of the ages that we treated in our practice, once our insurance called Medicare, which helps cover elderly patients, approved Venaseal, we found that the percentage of patients that we treated in our practice that were elderly went up a lot. And so we got quite a bit of experience with treating elderly patients with Venaseal. So some differences between our younger and older age groups, if we look at under 65, which is the non-Medicare age, and over 65, which is the Medicare patients, we found that the Medicare patients were heavier in terms of their BMI. They had more advanced venous disease. Almost half of them had SEEP clinical class 4 to 6. Their VCSS was higher, and we did not find that they had any increase in hypersensitivity reactions. So a case that I'll give you that I think was ideal for Venaseal was an 87-year-old woman. She had a long history of varicose veins and had painful ulcers in her legs. She had significant edema and pain, and we were putting her in compression wraps, but she found them quite painful and did not like wearing them. She had severe arthritis in her hands and back. In fact, could not sleep flat in a bed, but slept in a recliner, which made her edema worse. She had right-sided heart failure and atrial fibrillation and was chronically anticoagulated and walks either with a walker or a wheelchair. So her ulcers were a combination of varicose veins, heart failure, and dependency. And this is what her leg looked like. She had this very painful scaly area. She had this lateral ulcer over here. Her great saphenous vein was incompetent. This branch came over and went outside and right into this ulcer area. So here are my concerns. She had heart failure, and I did not know whether I would help her just by closing her GSV. Her volume status was tenuous. She was already on diuretics. Would she tolerate the tumescent if I gave that to her? She could not lay flat. She could not turn her hip out. Full anticoagulation was on board. She had thin, delicate skin and was not tolerant of pain. She had very low pain tolerance and did not tolerate compression well. So the question I asked is, should I really be doing anything at all? Well, she was really miserable from these ulcers, so I decided to proceed with this mixed picture of heart failure and edema, wounds secondary to this. I treated her in a semi-seated position, so it was a little bit uncomfortable for me, but very comfortable for her, and used Venaseal of her GSV, and then I did sclerotherapy in the ulcer bed. And I treated her legs one at a time, because her left leg also had some ulcers, but not as bad as the right. I did not do them together just because I didn't think she could tolerate the procedure for that long. So at 3 months, she had an excellent result to treatment. The scaly area here healed up. Her lateral ulcer healed. She's got still a little skin tear right here that was new, but overall, excellent results. So my lesson number 5 is that hypersensitivity is, it happens, it is manageable, and it's generally well tolerated. So we first noted hypersensitivity in the VCLOS and WAVES trials, and both of these trials noted that patients had a self-limited cutaneous or dermal reaction in the first several weeks after the procedure. This reaction was not typical for the phlebitis that we see after endothermal ablation. It was different. For one thing, it was itchy and usually not as painful as phlebitis. And when we noted it in our first WAVES trial, which was, again, 50 patients from our own practice, we looked at the impact of having this reaction on patient return to work and normal activities, and we found that it did not impact their ability to go back to work or their ability to go back to exercise. Their pain score at 1 week was higher if they had hypersensitivity than if they did not, but by 1 month that was gone. And currently there's only case series from different authors that look at severity of reactions of patients treated with cyanoacrylate. So what is a hypersensitivity reaction? Well, there's 4 kinds, and the type that we think is consistent with Venaseal is a type 4, which is a T-cell mediated reaction that usually occurs days to weeks after an exposure, and a rash is what you often see, and that's what we see with this. So on histology, this is from Andrew Jones' paper of an explanted vein. There is foreign body seen inside the vein, there is fibrosis, and there are T cells visible. So this is consistent on histology with a type 4 hypersensitivity reaction. So there's several literature reports. The one that I'm going to review for you was in 2020. We had 367 limbs. Our hypersensitivity rate was 6%. Most of these were mild, and I'll talk to you in a minute about definitions of hypersensitivity. There was a study also done in Thailand and one in Korea. And these had an increased rate of hypersensitivity compared to what we see. So there could be differences in different populations in how often they get hypersensitivity, but I think one of the differences may be that both of these authors found that it was increased if the vein was very shallow, if it was epiphyseal. And after our WAVES trial, we stopped treating epiphyseal segments. If it's very close under the skin, we usually do phlebectomy in that area and do not put Venaseal there. So that might be one reason why we had a lower rate of hypersensitivity. So the study that we did, we wanted to assess the frequency of hypersensitivity reactions in patients that we treated. We wanted to identify factors that were associated with hypersensitivity and then document the severity and what happened to these patients. So this was data from our site. And again, 367 patients in, limbs in 279 patients. And we collected a number of pieces of information about these patients. Our definition of hypersensitivity is that it's a distinctive dermal reaction with erythema, itching, and variable edema or pain. We defined it as mild if no treatment was needed other than over-the-counter medication. It was moderate if it required prescription steroids, and severe if it was recurrent, lasting more than 30 days, or required explantation of the vein. So these were our patients, and clinical classes ranged quite a bit. We found that the mean VCSS was 7. Mean age was 54. There were more women than men. These are the veins that were treated, and the mean vein diameter is shown here. The largest segment that we treated was 24 millimeters, and these are the various lengths and the volume of cyanoacrylate we used. 4.3% of our patients had a mild hypersensitivity reaction, 1.3% moderate, and less than 1% was severe, for a total of 6%. And we found that no patient had a hypersensitivity reaction in a second limb after the first one was treated if they were treated on separate days. So the severe reaction was a woman that had recurrent rashes, and they were not just over the vein that was treated, but she had a rash throughout her body. And we basically did an in-office stripping of this vein with tumescent anesthesia with 3 incisions, and she recovered. So this would be our severe, was 12.75, and the duration was 10.5 days. So most patients had this in about a week and a half is when it occurred. And we found that there was no difference in hypersensitivity by SEEP class, except for that the patients with the more advanced disease, there was a trend towards them having a less likely to have a hypersensitivity reaction. We also looked at factors such as gender, age, race, BMI, VCSS, and volume of cyanoacrylate, vein size, vein length, and found no predictive factors there. Over time, however, the incidence of hypersensitivity in our practice has been dropping, and we think that there's a few differences in our patients that may or may not be explaining it. We found that the patients are older now that we're treating them, although with breaking them into classes of 65 and older versus under 65, we found no difference in hypersensitivity. But if you cut it up a little bit more, we find that the patients that are over 75, the very elderly, are less likely to have hypersensitivity. We found that we're now treating more advanced disease classes than we used to, and that the patients are heavier than what we treated when we first started doing Venaseal, probably because they're older. So what are we doing different that would drop the hypersensitivity rate? Well, we screen patients for adhesive allergy. We ask them a lot of questions about, do they have reactions to adhesives? We wait a full 30 seconds after our last injection before we resheath the delivery catheter. So we never pull the catheter through the subcutaneous tissue and expose glue to the subcutaneous tissue, which I think makes it probably is the biggest difference. And in some patients, we do selective skin patch testing. This has not been validated. This is an example of a positive patch test. This, again, is not something that Medtronic necessarily at all recommends, but something we do in our practice. And here's an example. So some caveats and limitations for our studies. The data may be skewed as we've become very diligent about tracking hypersensitivity. The difference between hypersensitivity and phlebitis isn't always crystal clear, and again, skin testing has not been validated. So some other considerations or lessons from using Venaseal. What about veins above the fascia and how low? We treated epiphyseal veins with waves up to 32 centimeters out of fascia. And we found no difference in post-procedure pain or days off work in these patients, and they had good improvement in quality of life. However, I think that they can get hyperpigmentation, and I do believe that cosmetically it's not the best way to treat the vein if it's right under the skin. And I have a hunch that it's maybe cause some hypersensitivity as well. You can ablate as low as you wish in the leg, but I would not ablate over the medial malleolus. Do stockings need to wear stockings? Well, in the V-Close trial, they did, but they did not for the European trials or the WAVES trials, and we do not have our patients wear stockings afterwards unless they want to. This does not seem to influence vein closure rates, and it's unknown really whether they make the patient more comfortable afterwards. I tend to think that they don't. However, again, if the patients like stockings, they can wear them. If we do concomitant treatment like microphlebectomy or echosclerotherapy, we will. What to expect afterwards? Most patients are very comfortable on the day of the procedure. If they become sore, it's usually days 5 to 10. Some patients will feel a pulling sensation for a while. And in our practice, again, that they can get hypersensitivity. I tell patients 3 to 5% in general. And time back to work and normal activities is really very fast, and branches can take up to 3 months to go away. So in summary, short-term recovery is well tolerated by most of our patients with Venaseal. I think it's excellent short-term recovery. Long-term outcome data is also excellent. I think staging branches is a good strategy for many patients. I think that the elderly in particular benefit from this technology, as that case I showed you demonstrates. Hypersensitivity should be recognized. You should counsel your patients about it. Tell them to call you if it occurs, because usually you can treat it with antihistamines, nonsteroidal anti-inflammatories, sometimes hydrocortisone on the skin, and it will go away. And Venaseal is an innovative tool for the treatment of saphenous insufficiency. I want to thank you very much, and I wish I could be there in person to answer your questions. Thank you.